Hi, everyone. My name is Jean. I'm a clinical dietitian and CNSC in Chicago and a member of DNS. If you caught my first video on this TPN electrolyte series, we covered a case study specifically, and we covered sodium, potassium, phosphorus, and magnesium. So today we're going to broaden things out a bit, and instead of focusing on a specific case study, we're going to talk more broadly about other things that we add to TPN, which are calcium and then insulin. And we're also going to talk about everyone's favorite subject, which is chloride and acetate, or the acid-base balance in the TPN. All right, we will go ahead and start with calcium. So in terms of dosing, calcium is pretty easy. Standard dosing is anywhere from 10 to 15 milliequivalents per day. Something to keep in mind is that, we know that serum calcium is not closely tied to our calcium intake. It's more so related to, vitamin D deficiency, hypoparathyroidism, hyperparathyroidism, immobility, critical illness, malignancy. These are all things that can affect your serum calcium, and they affect it more strongly than intake. So this is why it can be okay to leave calcium out of the TPN, even though it might seem like, ooh, should I be doing that? But if you need to kind of prioritize providing either calcium or phosphorus, generally speaking, you want to stick with providing adequate phosphorus because that is something that your serum phosphorus relies pretty closely on your phosphorus intake. So we do have to make sure we're providing adequate phos to maintain adequate serum phos so that all of our organs continue functioning. So calcium is something that it seems like it can either fit in the TPN or it can't, and that depends on a bunch of different factors. So that includes calcium and phosphorus solubility, which is affected by the amino acid solution that you're using. So the brand, the concentration of amino acids, the amount of the amino acids. It'll depend on the pH of your solution. It actually also depends on the order of ingredients that you add to the TPN. So whatever you're adding first and whatever you're adding last, that will affect the ability of calcium and phosphorus to precipitate or hopefully not precipitate. Your concentration of dextrose in your solution is also going to affect the solubility. Whether you use calcium gluconate or calcium chloride. And then additionally, if you're using a 2-in-1 solution, so dextrose and amino acids with separate lipids versus a 3-in-1. So all of those factors affect calcium and phosphorus solubility. So this is something that we don't have a ton of, control over. This is more so a pharmacy. We as dietitians, this is more so something that you're going to have to work with your clinical pharmacist pretty closely on. They should have, a system in which they can input values, and it'll tell them whether or not the calcium and phosphorus that you're trying to put into your TPN is appropriate, or if there's a risk for precipitation. So there are a few steps that we can take to reduce the risk of calcium and phosphorus precipitation in our TPN. One of them is to use calcium gluconate instead of chloride, so that is just less likely to precipitate. Of course, 2-in-1 solutions instead of 3-in-1 total nutrient admixtures, those are more opaque and are harder to identify precipitates. So maybe not reducing precipitation risk, but reducing your risk of missing it. You want to make sure you're not infusing a solution that's over 24 hours old. So we like fresh TPN. You want to keep the total of the calcium and phosphorus added together less than 45 milliequivalents per liter. And all of this information I've gotten and checked my sources with a website I like to use that's called rxkinetics.com. I was introduced to this by one of my pharmacist friends, and it's very helpful. They use it a lot for determining solubility of calcium and phosphorus and many other things to do with TPN. So I'd encourage you to check that site out. And as always, consult with your interdisciplinary team. Make sure you rely on your pharmacist. They will have a lot more information available as to calcium and phosphorus solubility because it will change based on the amino acid solution that you're using. And there are some solubility curves available. So depending on the brand of amino acids that your facility uses, you will have a different calcium and phosphorus solubility curve to follow. Okay, one thing that we can add to our TPN bag, depending on policy and procedure, wherever you work, is insulin. So whether or not someone is diabetic at baseline, they may have difficulty with controlling their sugars on TPN, and you might be asked to add insulin to the bag. So when that happens, the rule of thumb that I've learned and that has been followed at the facilities that I've worked at is to add regular insulin. So no long acting nor no short acting here. This is just regular insulin. And you dose it based off of the grams of dextrose that you have in the TPN. So if you have a patient who does not have a history of diabetes and is insulin naive, the rule of thumb is to start with 0.05 units of regular insulin per gram of dextrose in the TPN. If you have a patient with a history of diabetes who is not insulin naive, then we start at double that. So we start at 0.1 units of regular insulin per gram of dextrose in the TPN. Of course, with insulin, there are a few things that we want to be careful about and cautious with, since it is something that, it can be a bit dangerous. So we want to avoid insulin stacking. So that means combining different types of insulin so that their onsets of action will overlap, potentially creating hypoglycemic events, which of course we want to avoid. So make sure that, if you're adding insulin to the TPN, that everyone knows if the patient is on basal insulin, if they're getting a sliding scale for coverage, if they have any sort of other hypoglycemic agents on board. We want to make sure everyone on the team is aware so that the glucose can be monitored accurately and we can avoid creating any sort of hypoglycemia. Another thing to keep in mind is that once insulin is in the bag, it is in the bag, and that is what you have to run for the next 24 hours or however long you're running your TPN. So once it's in, it cannot be taken out. So it's always better, in my opinion, to shoot on the more cautious end and provide maybe, if you're thinking of a range, maybe to provide the lower end of the range of the insulin. And you can always adjust either up or down the next day based off of the labs. So make sure that everyone, including your primary provider, your nurse, pharmacist, other dietitians that might be covering your patients, know that there is insulin in the TPN. So everybody should be on the same page in terms of the amount of insulin that you're providing and if there's any other sort of insulin or hypoglycemic agent that the patient's going to be getting. Another thing to keep in mind is that if you're starting the TPN at a quarter or a half goal dextrose, that you provide a quarter or a half of your calculated insulin, so that you're not, providing insulin to cover your goal dextrose without actually providing goal dextrose. And as always, keep in mind, hypoglycemia is much more dangerous than hyperglycemia. While we do shoot for that glucose range of 140 to 180 in the ICU specifically in our critically ill patients, we want to make sure that we're not causing hypoglycemia because that is more dangerous. So our next topic to talk about in TPN is the acid and base balance. So that's going to be based off of the chloride and acetate salts that we have in our TPN. So there's a lot of factors that are going to affect this particularly. One of them is your amino acid solution. So just like your amino acid solution will affect your ability to add calcium and phosphorus in that solubility curve, it's also going to affect the amount of chloride and acetate in your final TPN solution. So I pulled a couple examples of amino acid solutions that I've worked with before. So Aminosin 10% is one that I've used, and that one actually contains no chloride, and per liter it has 111 milliequivalents of acetate. In contrast, Travasol 10% has per liter 40 milliequivalents of chloride and 88 milliequivalents of acetate. So there's kind of a wide variance depending on the brand and concentration of amino acids that you're using. You might have some that have no chloride or some that have a more balanced chloride and acetate content. So I made up kind of a a solution and dosage of amino acids to use for this example going forward. So I'm going to say that we have a TPN, we're using 10% Travosol solution, and we're going to use 900 milliliters of it, or 90 grams of amino acids. So if we're using 900 milliliters, and each liter has 40 milliequivalents of chloride and 88 milliequivalents of acetate, that means in our 900 milliliters, we have 36 milliequivalents of chloride and 80 milliequivalents of acetate. So between the two of those, we have 116 total milliequivalents, which that's important because we're going to create almost a pool of milliequivalents with which we can kind of allocate some to chloride and some to acetate. And this will make sense, hopefully, more in a minute. So the chloride and acetate in milliequivalents that are provided by your amino acid solution are going to be the minimums for each chloride and acetate that you can have in your TPN. So if you have an amino acid solution that has no chloride, for example, Aminosin 10%, theoretically, you could create a TPN solution that has no chloride if that was something that you needed to do. But many of them have a balance of chloride and acetate, and those numbers are going to be the minimums that you can use because you can't change the concentrations in the amino acid solution unless you change the volume of amino acids that you're using. So when you're thinking of chloride and acetate in your TPN, it has to be bound to something. So when we're adding our electrolytes, so our sodium, our potassium, our phosphorus, those all are in the form of salts. So we're either going to be adding sodium chloride, sodium acetate, or sodium phosphorus, sodium phosphate, or potassium chloride, potassium acetate. They're all in forms of salts. We're not adding the individual elements into TPN. If you remember from like high school chemistry class, if we tried to do that, it would explode. So we're going to start with our sodium and potassium. So what you need to know is the total milliequivalents of those two electrolytes that you're going to be adding to your TPN. So for this hypothetical situation, I'm saying that we're going to add 120 milliequivalents of sodium. So that can either be in the form of sodium chloride or sodium acetate or some combination of the both. So in order to, match the milliequivalents of sodium we're providing, we need to provide either chloride and or acetate in the amount of 120 milliequivalents. In the same sense, then we're going to have to provide 55 milliequivalents of chloride or acetate to match our 55 milliequivalents of potassium that we want to put in this TPN. There is one wild card, and that's phosphorus. So some of your milliequivalents from that addition of sodium and potassium, so ours would be 120 sodium plus 55 potassium, so 175 total. Some of those milliequivalents are going to be used up by your phosphorus salts. So the option for adding phosphorus to TPN is either the form of sodium phosphorus or potassium phosphorus. And generally, sodium phosphate is preferred. So, and that is in the form of millimoles. So then you have to do the fun conversion of milliequivalents per millimole. So sodium phosphorus, which is the one that we'll use for this hypothetical TPN, is 4 milliequivalents of sodium per 3 millimoles of sodium phosphate. So if we want to provide 36 millimoles of sodium phosphate in our TPN, that accounts for 48 milliequivalents of sodium. So the way that we got that number was taking 36, which is our millimoles of sodium phosphate, and multiplying by 1.33 because the sodium is in a 4:3 ratio to the sodium phosphate. So we've got 48 milliequivalents of sodium that are being used up essentially in our sodium phosphate so that we no longer have those available to bind either chloride or acetate. So we take all of these numbers and we do a bunch of math. Pretty simple math, but it's, a lot. So we're going to do 120 milliequivalents, which is our sodium amount. We're going to add 55 milliequivalents, which is our potassium. We're going to subtract the amount of milliequivalents that we're using up to bind to phosphate. So that's 48. We're using up 48 of our milliequivalents of sodium binding to phosphate. And then we're going to add the total amount of chloride and acetate ions in our amino acid solution, which ours was 116 because it was 36 milliequivalents of chloride and 80 milliequivalents of acetate. So we've got 120 plus 55 minus 48 plus 116, and that gives us 243 milliequivalents of ions available to add to either chloride or acetate to form salts. So we have our total number, and we know that 36 milliequivalents has to be chloride because that's coming from our amino acid solution. We also know, on the same vein, that 80 milliequivalents has to be acetate because that is also coming from our amino acid solution. So depending on our clinical picture, what your patient looks like, what their goals are in terms of lab values, etc., what their disease state is, you might want to provide more chloride, more acetate, or a balance. So I've got a couple of clinical scenarios here that we can look through. So say our patient is really hyperchloremic. They've got a serum chloride of 126. Maybe their serum bicarb or their serum CO2 is 11. So they're pretty hyperchloremic and probably a little acidotic. So we might want to provide the least amount of chloride as possible so we bring that balance back and we don't exacerbate their high chloride. So if we're providing the least amount of chloride possible, we know that that is 36 milliequivalents because that is the amount from our amino acids. So we're going to take our 243, which is our total ions, that is our ion pool. We're going to subtract the 36, that is the chloride, and we're going to subtract the 80, that is the acetate in the amino acids, and that gives us 127 milliequivalents left. And we've decided that we want to give this all as acetate salts because we want to minimize the amount of chloride that we're providing to avoid exacerbating the already existing hyperchloremia. So we have sodium and potassium to give as salts. So we take our 127 and we know, we take our 120, which is our goal sodium. That was the amount of sodium that we wanted to include in the TPN in milliequivalents. We know that we're already providing 48 milliequivalents of sodium from sodium phosphate. So we're going to do 120, we're going to subtract 48, and we get 72 milliequivalents of sodium that we have left to provide. And we want to do that in the form of acetate. So our order will include 72 milliequivalents of sodium acetate. And then with potassium, it's a bit easier because there's no potassium phosphate that we're including. So our 55 milliequivalents of potassium that we want to include in our TPN is all going to be acetate. So that's 55 milliequivalents of potassium acetate that will be in our TPN. So let's say that now we're on the next day. We're looking at the labs on this same patient who we just wrote TPN for. And their labs get a little bit better. So their serum chloride the next day is 113, still high, but a lot better. And their serum bicarb is 13. So still a touch low, but a lot better. So another thing that we're going to throw a curveball in here, let's say that the patient's potassium dropped to 3.4. So now we want to add another 40 milliequivalents of potassium to the bag. So we're adding 40 milliequivalents of ions, essentially, that we will have to provide as either chloride or acetate. So our TPN from yesterday had 243 milliequivalents of total ions in our ion pool from which we could draw to make acetate or chloride. We're now adding an additional 40 for a new total of 283 milliequivalents. So again, from our amino acids, because we're not changing those, we have 36 milliequivalents obligatory of chloride, as well as 80 milliequivalents of acetate. So we do our 283, we subtract 36, we subtract 80, and we end up with 167 milliequivalents that we will have to provide as either chloride or acetate salts. Our chloride and bicarb on the labs have improved drastically, but they still remain a bit hyperchloremic. So instead of doing minimal chloride and maximal acetate, we might want to do something closer to a balance. So I picked a ratio of 1/3 chloride to 2/3 acetate to hopefully further correct the imbalance, but not quite as drastically as we did the day before. So we're going to take our 167 milliequivalents and we're going to multiply that by 1/3 to get 56 milliequivalents of chloride. We're going to take the 167 and multiply it by 2/3, or just, subtract 56, and we end up with 111 milliequivalents of acetate that we need to provide. So we have options, right? So we could do any combination of potassium chloride, potassium acetate, sodium chloride, whatever combination it might be to get to those total numbers of 56 milliequivalents of chloride and 111 milliequivalents of acetate. So, for example, any combination that gets us our new goal of 95 milliequivalents of potassium, so that's the 55 that we originally wrote for, plus the 40 additional to correct that low potassium of 3.4. And then the 72 milliequivalents of sodium that we have left to provide after we've subtracted 48 attributed to our sodium phosphate from our goal of 120. I say let's do 56 milliequivalents of potassium chloride. That gets us our 56 milliequivalents of chloride that we need. So now we think everything else should be acetate. So to make up for the rest of the potassium that we need, so we take 95, our goal, we subtract 56, which we just wrote for as a chloride salt, and that leaves us with 39 milliequivalents of potassium to provide as an acetate salt. To do the rest of that, our 72 milliequivalents of sodium, we want them all to be acetate because we just used up all of our chloride with potassium. So we're going to add 72 milliequivalents of sodium chloride to the bag. Another option would be providing 56 milliequivalents of sodium chloride. So there's all of our chloride that we need to provide. And then doing 95 milliequivalents of potassium acetate and providing the rest of our sodium as 16 milliequivalents of sodium acetate. So it's kind of just a little math that you can choose, what you want to provide in terms of potassium chloride versus acetate or sodium chloride versus acetate, knowing that in total, in order to meet that 1/3 chloride and 2/3 acetate ratio, you want to provide 56 milliequivalents of chloride and 111 milliequivalents of acetate. So if you have any questions, please leave them in the box below. I hope this was helpful, and we will see you in our next video.